Hello, welcome to Level 4 Health and Social Care, Unit 406 Sociology Concepts in Health. And with this session, we're looking at part 3 of the unit, Measurement and Inequality. Okay, so the objectives we're focusing on today from your criteria are 3.1 to discuss how social inequalities influence the life chances and health statuses of individuals. And we'll be looking at 3.2, discuss how the government measure morbidity and mortality across the UK. Okay, so there are many other statistics that the government gather. I might mention a few along the way, but we'll be focusing on, from the answer for your assignment, just need you to focus on morbidity and mortality. Okay, so there's no real need for you to write on any other sets of statistics. Okay, so just to introduce, we're going to start looking at statistics first, and morbidity and mortality, and then in the second part of the session we'll go on to talk about inequalities. Okay, let's have a look. Health statistics can be collected on a systematic and ongoing base, or sometimes they just do them intermittently, which when they do the one-off health surveys, maybe about a specialist subject, or maybe for a university to do a piece of research, or sometimes they just dip into again a sort of snapshot of the country as a whole. But there are other statistics that are collected on a regular basis. Sometimes they can be the entire population, and sometimes they can just be a sample. As I said, if it's just a snapshot, they may just look at all the people of a certain age with cancer, for instance, depending on what the research needs. Just the mortality and morbidity data in the UK is actually collected separately in England, Wales, Scotland, and Northern Ireland. Some people forget that the UK is actually made up of 4 separate countries. And sometimes that can make comparisons between the countries a little bit problematic because they don't always standardize. They like to do things in a certain way. So they may not, the researchers often have to try and find a sort of way to find out where they're saying the same sort of thing, really. Okay. In England, most of the health statistics are published by the Office of National Statistics. A large amount of that is available electronically. So if you go onto the ONS website, you can pretty much find all the statistics that you need. Okay, so where are the sources? Where do we get this information from for our statistics? So the continuous stuff, mortality data in England and Wales comes from the registration of deaths as certified by the attending medical practitioner or by a coroner if they be the one who's doing it. They go through somebody else in Scotland known as the Procurator Fiscal, which is a sort of legal role. So they probably have a medical practitioner feeding into the procurator, and then all the information is gathered by them. Death certificates for all countries will include information on the immediate and underlying causes of death, the person's age at death, their sex, their address, and their occupation. And death certificates or copies of them are then sent to the Office for National Statistics, where the underlying causes of deaths are classified. And there's a particular chart that they classify things to, and this gets revised on a regular basis. At the moment, we're at the 10th revision, and it's known as the International Classification of Diseases, or the ICD-10. Now, this international classification is used all across the world. I wouldn't like to say that every single country uses it, but a lot of countries do. So that when you're doing research using the different classifications, like certain types of cancers, etc., heart disease, then you will be probably using, if you were doing something in Malaysia, they would use the ICD-10 as well. So at least you know that your research would be the same. If you're doing it in America and other parts of Europe, they all use the ICD-10 classification. Mortality statistics for England and Wales, as I said, are compiled by the ONS, and they're published annually. And these are the sort of groups of statistics that are published. So this is what you really need to know to answer the question that you're going to be looking at. We've got mortality statistics, cause. So this is where the stats go by cause, and it's known as series DH2. So if you want to look it up more, you go onto the ONS website. I'll have a link at the end for that, and you can just look up series 2, and it'll be all the statistics on deaths, and it will be listed by cause of illness. The next grouping is mortality statistics, childhood and perinatal. That's series DH3. So that's all the analysis of perinatal deaths, infant deaths, and stillbirths. So really in those very early years, really. Probably under the age of 1, I think, but you can check that. And the data on deaths of children in general. So that's broken up into different areas. Series DH4 is very focused. It's about people who've died via injury and poisoning. So it'll be accidents, violence, and poisoning. So accidents and violence, poisoning is a bit out on its own, but accidents and violence, as you can imagine, there are probably huge statistics. People who have either died via an accident, a car accident, or a murder, really. And that's series DH4. So not a medical issue, but something might have been a completely healthy person, but something happened to you. The other thing is known as Health Statistics Quarterly. You can also look this up online, and then it brings together quarterly information, so it sort of summarizes the information. So quite good for you to look at trends as well. And that presents quarterly information on all deaths, really, childhood mortality, and general trends in health. What diseases are big at the moment and what diseases are not. What are people suffering from? What are they dying from? So in the winter, you'll see big high numbers for flu, then that'll disappear. Obviously, during COVID time, we had high numbers for COVID, so that was a bit of an unusual. But also, Health Statistics Quarterly looks at trends in cancer survival. How many people die, how many people don't die with certain cancers. So it helps them sort of really do their research into how long people are surviving. Abortions, congenital abnormalities through birth, babies that die, babies that survive, that sort of thing, and general morbidity. The mortality data for Scotland and Northern Ireland is all the same data is available, but it will be through their relevant national statistic offices, and it'll be laid out in pretty much the same way. It may look slightly different. So for your research, if you just use the ONS, Office of National Statistics, which is England and Wales, it will give you enough information, really. So possible weaknesses, I have identified that sometimes different countries have slightly different types of statistics, so sometimes comparing can be difficult. But the other sort of criticism is that while the data is probably some of the most complete and accurate that you'll get, because it is a government requirement that all deaths, and it's quite serious if a death's not recorded, there'll be legal action taken. So there is a sort of reasonably decent accuracy about them. The weaknesses could be about misclassification. And it's like if people are inaccurate in their diagnosis, they might say you diagnosed with pneumonia where you might have died of flu or something like that. we can't really go back and change that. So that was really down to the experience of the attending medical practitioner. They might spot something more unusual. Otherwise, with older people, a lot of things get pushed under old age or dementia, or when in fact sometimes they can be other things. So that's a little weakness. And also people literally, making mistakes. So they're looking it up in the ICD-10 and maybe they're putting the wrong number down or something like that. So they're coding it wrongly. So those sort of human mistakes. Generally, though, they're fairly accurate. So where do we get all this routine morbidity information from? So data on morbidity is not quite so easily available as mortality because everything comes from the death certificate. The death certificate has to happen for everybody. It's very easy to get the information. Morbidity is maybe not quite as clear. So where do we find that information from? We find it from registrations, cancer registrations. So certain illnesses are actually registered. There is a register of people who are suffering from cancer or people who are dying from cancer. That's not the same for all illnesses, but some of the sort of big illnesses are registered. Statutory notifications. So if there are certain infectious diseases where there needs to be a legal notification to central government, so that they can manage any form of contagion. So that's quite, they're pretty accurate. Any laboratory reporting of microbiological data, and GPs reporting, because GPs regularly do reports on the sorts of things they've been dealing with in their surgery. So any clinical data reported by a GP. Whenever someone is admitted to hospital, there will be data on what they've been admitted with. Any data from health surveys, which I said, can be done by universities now and then when they're looking at something, but that data will be available to the central offices. Or every now and then we do the health surveys. I'll tell you a little bit more about that later. And if GPs practices, sometimes large practices might do their own little bit of research just to see what they've been dealing with over the last 6 months or something like that. And the weekly returns that GPs make to their Royal College. And again, they make returns so that the college has an idea of the sorts of things they're dealing with. So this is where morbidity data tends to come from. These are your sources. So looking at something like cancer statistics, because it's one of the big nationally reported issues. In England, they're conducted. There's a whole load of different regions, and it's recorded in the region. So there are 9 different regions, and they collect this data about incidents of residents in their region. So they need to get them from GPs. So they need special agreement to do that. And they supply the cancer data to the ONS, and the ONS gathers it for the whole country. And they tend to be published annually, but they're usually published about 3 or 4 years after the year the cancer was diagnosed. So if you have a cancer diagnosis like this week, your data won't get reported about 3 or 4 years because it takes quite a long time for them to gather all the information. So if you think the cancer stats are always a bit 3 years behind, so just bear that in mind. There's national and regional information, and statistical tables are gathered together, and newly diagnosed cases are recorded. So there is an ongoing sort of number, and they do that by age group and sex as well, so that you can sort of see. They use age standardized rates, European standard population, so it'll be like, the groupings of ages, like 25 to 35, 35 to 45, those sorts of things. There is a European standard that's used, and that really makes putting together people's information a lot better. So if I wanted to get something from France, I'd have the same age grouping, so I could do quite a nice comparison. Cancer registrations in Wales are coordinated by the Welsh Cancer Intelligence and Surveillance Unit. So if you want to find out about those, just go on and look for their website. Cancer registrations in Scotland are part of NHS Scotland. So again, you'd go through their information and statistics division. When they interpret cancer registration data, they need to take a bit of care when they're looking at trends, because they may differ in different parts of the country in the way that it's been collected and how complete it is. So not every region might do it quite as well as the other one. So something just to think about, really. And there can be misclassification, again, as I said before, and that could be down to the quality of the person who's making the diagnosis. Or they could change the diagnosis later on after things develop and not go back and change the registration. Or they could just get the coding wrong from their lists, a bit of human error there. So it's the same as the others, really. I mean, we say they're weaknesses, but really they don't happen that much, and they probably don't make a massive difference to the stats. Another group of morbidity information is hospital episode statistics, generally known as HES. So the Department of Health gathers all hospital episode statistics, and they really sort of all the people who come in for inpatient treatment. They've been collecting this since 1989, and it's noted by diagnosis or operation or both, and any particular specialities. And they generate about 12 million records a year. As you can imagine, there's quite a lot, really. And it gives you quite a lot of information. It gives you clinical information about the people who've been diagnosed or operations that they've had, because not everybody is treated by surgery. Some people are treated by medication and that, so it's about diagnosis as well. And that data can be age group, sex and ethnicity is gathered, so you could actually look at trends in that area. Geographical information, where the patient was treated, where do they live, and it helps when we're looking at things like deprivation and inequality, as you'll sort of find out later on. That could be quite valuable. How long they were in hospital, how long they waited to get their operation, those sorts of things. Whether they're on a waiting list, whether they're an emergency. And it gives you a huge picture, really, and you can do quite a lot of work with that. Statutory notifiable diseases are infectious diseases which are listed by the government and the Health Protection Agency to be recorded, and that's a legal requirement. If you don't register them, you are actually breaching the law, and it's usually because they are highly infectious or very contagious, and they need to control it. So they might need to isolate the individuals, or they certainly might need to monitor them. And there's quite a lot of lists of these diseases. I've given you an idea here. This is a lot of them. There's probably a few others I haven't remembered. These are the infectious diseases, but there are other notifiable issues such as Legionnaire's disease and that, which is contaminated water. But these are the actual contagious diseases. Anthrax, botulism, not things we see very often. Coronavirus, you'll see, is on the list there. That's sort of a newie since 2019. Diphtheria, measles, mumps, these are the childhood diseases. Polio, mainly because paratyphoid, polio, plague, rubella, they really have been eradicated from the UK. So, and typhoid, those sorts of things. So once they turn up, and TB as well actually was eradicated for a period of time. And TB started coming back, and that was to do with, it was related to immigration for a specific part of India where the TB was coming back. So that they were able to manage that by actually identifying people and sort of testing them at airports and that. So it was quite valuable. Okay, so these are the notifiable diseases. These are ones where they just they may have to isolate, or they may have to monitor people's contagion. Another set of statistics, morbidity, is vital statistics. They're produced by the ONS. Yet again, you can click in and have a look at them. And they include data for the number of conceptions, live births, stillbirths, and general deaths as well. So this is really from a baby being conceived to being born or not being born. They actually put those statistics together. They start with the conception, and then if unfortunately a baby dies before it's born, or if it is born, and they really come from hospital, maternity wards, through the health authority to the local authority, really, and then that will be handed on to the ONS. And any studies for specific diseases. So again, there might be some areas that they might be worried about. Like I said, at one point, TB was starting to rear its head. We had people coming into casualty with TB, which hadn't been seen in the UK for, well, I don't know, 30 years or something like that. So specific studies were done. So anyone diagnosed with TB was brought straight up as well. After that, it went on to the notifiable disease thing. Okay. The other thing that adds to it, I mentioned earlier, was health and household surveys. Now, these don't happen all the time. They are annual, but they sort of move around, and they happen when they happen, really. So the general household survey is carried out annual, and that's not an NHS activity. It's carried out by Social Services Division because it's about social support. But that it still gets recorded by the ONS, Office of National Statistics, and it picks a random sample of 13,000 households in the UK. And the data it collects are things like socioeconomic factors, like, what is their health like? How often do they use health services? Do they smoke? Do they drink? How much? What their fertility histories are? Have they had how many children have they had? And what their employment is, education, and income. And it enables us to actually look at some of these equalities issue, this background information. And additional to the household survey is what is known as the health survey. That's not quite as old as the household survey. It started in 1991 by the Department of Health. But it's the same sort of thing. It's an annual survey of the people's health. And it really, they pick out a representative group of the general population and aim to provide a measure of the health status. So the overall health is what they look at. And each year, the survey focuses on different demographic groups or on diseases. So they'll sort of decide at the beginning what they're going to be looking at. So different demographic groups. So they may look at, all working class people from ethnic minorities, and they'll do a very focused piece of research on sort of diseases that have been appearing for them and what sort of risk factors there are. Or they may do all middle class white users in the north of England or the south of England, and they'll look at, and eventually they build up. So over a few years they build up all sorts of different pictures. And they might be motivated by concerns, things that people, been raising concerns with them, or it might be something that a researcher just wants to do, or it might be something they've got an indication to do, or it might just be something they haven't looked at for a while as well. And they look at health indicators, so they look at things like cardiovascular disease, what sort of physical activity they're doing, what their eating habits are like. They complete a health questionnaire. And all those who are part of the survey get a nurse visit, and they get their physical measurements like blood pressure, breathing test, blood, saliva are all checked. So it's like they get a bit of a little MOT as well, really. And that will get published. Okay, I've given you some references if you want further reading. That's a link for the ONS. Okay, you can write that down, and then if you want to read a bit more, the ONS is always there to sort of tell you some stuff. So have a look at that. Okay, so that covers the two areas that you really need for your assignment, but if you want to look in more detail, as I said, do have a look at the ONS. Okay, so the next part of this part 3 section, we're going to look at inequalities. We're going to address the inequalities criteria, and I'm just sort of opening with a thought really about inequality. You probably know some of this, but sometimes it's just nice to be reminded of it. That the 8 richest people in the world have the same wealth as the 3.6 billion poorest people. So if you add the personal wealth of the 3.6 billion poorest people in the world together, you will get the personal wealth of the 8 richest people in the world. So take a moment to think about that before we go on and start to look at inequalities. Okay, so how do we define health inequalities? I've got a nice definition here for you, which I think is useful. It's by the one of the directors of the King's Fund, which is a big research fund in the UK. Looks at all sorts of health and social issues. The definition is it's an unfair and avoidable. Please note the enlarged words. Differences in people's health across social groups and between different population groups. It's unfair because these health inequalities do not occur randomly or by chance, but are socially determined by circumstances largely beyond an individual's control. These circumstances disadvantage some people and limit their chance to live a longer, healthier life. Health inequalities are avoidable because they are rooted in political and social decisions. So it's reminding you it can be avoided, it can be changed. Okay, so although the person who is unequal probably doesn't have it in their power to change it, the people who run the country do. So just bear that in mind. Okay, how do we measure inequality? Well, there's something called the Gini coefficient, not Genie as comes out of the magic lamp, but an Italian sociologist whose name is Corrado Gini, Gini. Okay, and he created this statistical measurement. You don't really need to do this, but I just thought you might find it interesting, really. And it's actually quite simple. It just operates between 2 points. And the first point is 0. If you can have a look at the picture of my chart there, 0 is where we have total equality. Everybody has equal income. So nobody is better off than anybody else. Now, we know that's, well, it doesn't exist in any society that I know. But, you know, Genie had to start somewhere. So his first point is 0. And then all the other countries in the world sort of fall somewhere in between, and he's got 0 total equality and 1 is maximum inequality, where one person owns all the money and everybody else has got nothing. Now, we haven't got anybody at 1. There are probably no countries where everybody's at 1. We know there are no countries and everyone's at 0. So every other country is somewhere along the line continuum between that. So if you're a 0.5 country, then half of the people in your country are equal and half of the people are not. So, you know, if it's higher than 0.5, then it starts to become more and more unequal. If it's lower than 0.5, like 0.2 or 0.15, then actually the country has more equality. That makes sense, yeah. If you're interested in that, just look up the Gini coefficient, but they can get quite complicated with all the equations that they do, but that's really the basis of it. So a very unequal country will be in 0.5 and above. A more equal country will be below 0.5. So as I said, some countries are more equal than others. So it's, as we know, it's not natural. So it's really to do with the social policies of a country, how they bring it around. So there are some countries, Norway, Sweden, and Iceland, nearly always turn up at the global indexes for happiness, equality, and well-being. And really, if you want to look into that a little bit more, you can do a bit of research in that. It's all about their social policies. Their policies orientated to maximising overall welfare for their citizens and creating a good society. So have a little bit of look at that, but do bear in mind that one of the things they do is to make sure that people are more equal. They often spend much larger amounts on taxes than other countries do, because the state provides a lot of stuff or supports quite a lot of people who can't quite make the grade. So it means that the people who are doing okay tend to pay much higher taxes in those countries. And the cost of living is also quite high as well. But that is it. However, in countries such as the UK, we've got a bit of a reverse view, really. And over the last, I would say, 30, 40 years, some of the policies that have been acted by both the major parties, really, mainly the Conservatives, but Labour have done their share, have sought to bring about a less equal society. One of the areas that has been really visible is taxation for the very, very high earners has actually been reduced over the last 30 years. So in 1983, the very top tax rate was 83%, which is huge, actually. 83% of someone's earnings was went in tax. Okay, was taxed. Whereas that we're talking about the highest. We're talking about millionaires here, and company owners and things like that. Whereas the top tax rate has actually slowly dropped and dropped and dropped to 45%, really now. So you can have someone who's a millionaire who's only taxed on 45% of their income now. And then that drops down and down again to where most people are taxed on 20%. Okay. So really, the money that we've been getting from the ultra rich has dropped over the last 30 years, and that's because a capitalist society, so they don't really like doing things like that. Other reasons for inequalities is a decline in the traditional skilled blue collar work. So in the 50s and 60s, particularly in the UK, mainly men who didn't leave school with academic qualifications could find pretty good work in engineering, shipbuilding, factories, so in the manufacturing sector. And these jobs were sort of manual skills and they're crafts, but they needed to be learned on the job. And they would go in quite young, straight after leaving school, about 15, 16, and do apprenticeships and learn on the job, like be an electrician, be, an engineer, those sorts of things. And that sort of work is disappearing now because manufacturing is disappearing from the UK particularly. We're not really making things that much. We still have some of the car factories, but we only have half as many as we had in the 80s. And it's on a downward sort of incline. Why? And that's because of globalization. More things are being built abroad and being brought into the country cheaper, so we're no longer manufacturing. And the British economy really has decided, well, okay, we're going to give up with manufacturing. And one of the areas that we're quite good at is finance. So a lot of energy has gone into managing finance, which is fine, but it doesn't give the slightly less well-educated people decent jobs with good pay. Whereas the car factories, the small light engineering companies did. Declining trade union power is another reason for inequality. There's been a sharp fall in the number of workers who belong to a trade union. 1979, we had over 13 million workers in a trade union. 2013, that figure's down to just over 7 million. I would say it's probably gone down again in the last 10 years to a lot less than that. Because a lot of these manufacturing jobs that have been lost were very trade unionized. So one element of the trade union is its ability to negotiate to protect wages and working conditions for the union members. And it's been very difficult for companies that don't have unions to be able to negotiate for salaries, and not just salaries, but terms and conditions, like how many breaks do you get? Do you get any holiday? Do you get any sick pay? All of that stuff was brought around by the unions. So losing the unions means it becomes very hard to negotiate, even if you started off with some of these facilities. In countries where we've got much lower inequality, such as the Nordic countries, as I mentioned before, and Germany, trade union membership is much higher. So we can actually link that trade union membership with reducing inequality, really. In Germany, it's an absolute law that anyone who's got over 500 people, their trade union representative must be on the management board. So they're actually quite actively part of the decision-making process. Doesn't make them perfect, but it makes them better off than some. Another source of inequality, wealth. I've already mentioned taxes. And there's been some rapid growth in inequality because of the fact that our focus in this country has been on finance. And it's more about profit interest, really. And that the small elite society have been investing their money well and making more of it. So it's really not through hard work, or employing lots of people and therefore giving them work, but it's someone who sits at home, you know, with a lot of money in the bank account and just paying one guy to move stuff around so that he gets more money in the bank account. So it's a very different way. So the ultra rich usually get richer by investment. Investment is something that doesn't take any work at all. Well, some people say it does, but you know, in a great scheme of things, you don't employ a team of people to do it. So and also in turn, those who develop wealth hand it on to their children. So the children really have done nothing for the wealth apart from inherited it. So that rich 1% owns a huge amount of the wealth of the country, but they don't share it. So the relationship, we talked there about some of the causes of inequality in itself. So let's think about, you know, we've identified that it's an unequal society. So what is the relationship between health and inequality? And it's really worth highlighting that it doesn't imply that the reason for health inequalities are all explained by social processes. About 1/3 of our health situation is due to, you know, the sort of traditional risk factors that we know of and that we've discussed at length in other units: smoking, diet, drinking, those sorts of things. But that's really only 1/3. We've identified that taking that away, the remaining 2/3 of what causes inequality are social processes. So it's not all of it, but it's 2/3 of it. So Marmont has done quite a lot of work on health equalities, and he's very quick to point out that even though we talk about smoking, drinking as diet and choice, he says, well, if it was really just that, it would be much more random, you know, like he'd smoke and he wouldn't. But he's saying, you know, it's not that easy because you can actually predict that certain classes, smoking is higher in often more deprived areas than it is in less deprived areas. And he identified a researcher called Hilary Graham actually looked at lone mothers who smoked quite a lot and spent quite a lot of money on smoking, even though they had very little money to go around. And they said that the research showed that the end reason was that these lone mothers, it was the only part of their budget that they actually spent on themselves. Everything else was for the child and the family. So the unit actually described it as the only luxury that they had, because they could make their life bearable, really. So class inequality has been clearly regarded as a class issue, and a lot of work around class and inequality is done by Wilkinson and Pickett. And they say, although it affects everybody, there's a very clear gradient where different levels of advantage are distributed across society depending on where you stand, you know. So those in the middle class will have average better health, and the people in classes below them will have less good health, and the people in the classes above them will have better health. So we've got like 7 class here, really, from the upper class, middle class, down to the working class, and various different levels in between. As you can see, this is just a life expectancy chart, but 80 years at the lower class 7 and the higher class 1, another 5 years life expectancy. So we could really think about that being very clear, really. As well as class, there are psychosocial factors. And again, Wilkinson and Pickett carried on looking at these areas as well. And they wanted to go past just material stuff as money and poor housing and bad diet, and to explain how people feeling about their inequality can actually affect their health. And one of the things they identified was that these feelings of health equality can often bring around stress, and it can be, an ongoing chronic stress, which can really take control over people's lives. So they said that it was more to do some of the things we'd inherited evolutionary, that we'd always been poor and working class. You've always been poor and working class. You'll always feel stressed about that fact, and it can have a very negative impact on your health. Humans have also evolved to be aware, in their eyes, humans have evolved to be aware of their status in rank. So if you're poor or working class, you have that reinforced to you that you're not as important or special as the people who are, class 1. And people are quite sensitized to that, and they sort of expect it. And the experience and perception has affected their biological systems that negatively impact on their health. So, the feeling of being put upon and low self-esteem demeans people, saying that you're worthless, you're not as important as that one. That gets to you in the end, really. So we've started to talk about stress in the psychosocial, but stress on its own has really noted the negative effect. If stress is switched on for too long, often during work time, it has a highly damaging effect on someone's life. And the chemicals, the corticosteroids, which adapt for short-term stress, they become very maladaptive when you're in long-term stress, because you shouldn't be in long-term stress. The chemicals were created for dealing with changing your body just for short periods of time when you're in stress. So when someone's in long-term stress, that can have a real negative effects on your health, really. So you should not be in that situation. Your body's not created to be stressed all the time. Another thing that Wilson and Pickett looked at was issues about insecure egos, and I thought I'd just put this in. It's a bit of a rare thing, but I thought it might be interesting with sort of today's youth, particularly interesting. And this is about one of their concerns. It can be mistaken for high self-esteem, but those who are insecure egos exhibit self-promoting behaviours. And I've brought this in because it's about people going on Facebook, TikTok, etc., Twitter, um, posting loads of pictures about themselves, talking about themselves, and coming out of that, they can, if they don't get the likes they wanted, they could be perceive themselves as failures, and they can end up with anxiety and stress because of that, therefore affecting their own health. So Twenge and Campbell also identified that there is inequality in American culture, which is actually creating what they say at the moment is a narcissistic epidemic. So, and they say that there are people who are showing traits of what is known as a narcissistic personality disorder, which is generally quite rare, but they're saying that it's actually appearing in the general population. And this is this really unusual belief, like overestimating how good, attractive, and clever you are. And that's to do with Facebook influencing. If lots of people give you likes, you think you're really special, when in fact you might not be that talented at all. I don't know. People might just be giving you likes. I don't know, because your picture's good or something, or because you say something, one sentence, right? It doesn't mean to say everything else you've got to say is that important. Is that there is a real downside to this, and lots of people love it. They love being liked and adored. But sometimes the reality doesn't match the self-perception. So if someone comes away from their little TikTok world and then goes out into the real world where they start to talk to ordinary people who maybe don't follow them on Facebook or TikTok, then their self-perception, they might say, well, you're not that clever, you're not that special, and that can be quite difficult for them to deal with. And these include problems for that narcissistic person. It will affect their mental health, and it can affect their physical health as well, because they stop caring for themselves. And it can also impact the quality of their life, their friends and families, because they often don't really care about the people around them, because they get so driven. They expect, if you think of some of the young people who want to become influencers, they get so driven in what they do. Sometimes they don't focus on the safety aspects of what they're doing, and they could end up in a very difficult circumstances, which definitely could be dangerous to their health. Or other members of the family get completely ignored and not looked after, or they will, a mother might give up caring for herself, or spending all her money on buying all the latest clothes and trainers for the young person to reach their goals, and she could go without, and her health will suffer because she's not eating properly and that. So there are things to think about as well. This narcissistic epidemic that was identified in America, interestingly, in 2010. It's quite a long time ago now, really. But I have a worry that it's definitely happening in the UK. You may have experienced it around yourselves as well. Now let's look at some of the different types of disempowerment as well, because disempowerment is something that obviously causes inequalities. So there are different types of disempowerment. Material disempowerment exists when people just don't have the money or the resources to actually feed themselves, or to keep safe, or to dress themselves. And obviously this form of disempowerment can be, really quite serious, and it's relative to the country that you live in as well. So if it's a low or middle income country, it can mean having no or little food. It can be relative in a high income country, so you can have the same disempowerment, say like in the UK, as you can in Sierra Leone, really. But in Sierra Leone they may well be starving, whereas in the UK they may not have access to some of the things that they see to make their lives fundamental. I mean, they may well survive, but they will definitely consider to be in poverty. So it's all relative. Another type of disempowerment is psychosocial, again, and that's when people don't have control over their lives and they can't make the decisions that they want to, which would be good for their health and well-being. So when you've got sort of, as an example from Glasgow, which is a city in Scotland which has substantial health disadvantages there. And the communities in Glasgow often don't have a lot of control because there's been a lot of industrial decline and the communities have declined. And they don't really have the sense and purpose. There's lots and lots of unemployment. People are poor, living on benefits. So it really means that life happens to them that maybe they can't control what happens to them. You know, things just happen to them and they don't have any control. Another disempowerment is political, and it's a collective voice is absent. So it's like what I talked about, the unions disappearing and people's vote not making a lot of difference because maybe the two main parties are so similar that even it doesn't matter who you vote for, things aren't really going to change. Or that political group who's in power, maybe they've got a big seat majority and they're not going anywhere, and they're not really focused on the social policies that you need. So you've got no chance of changing it because you're not an MP, you're not, you know, you can vote, but the vote only comes around every 4 or 5 years. So in between, you're a bit stuck, you know. Criticism of some of the work, particularly around Wilkinson and Pickett, they have done a lot of work in this area. Some people say that Wilson and Pickett, you know, they focused on how things are and they didn't focus on how things got there. And they don't really analyze all the processes that maintains this. And Scrambler says that Wilkinson and Pickett stopped looking for causes too soon. And really, you know, spent more time just worrying about what the inequality was. So he's saying that he should look at, you know, look much more deeper into the structure of social class. But Wilkinson wasn't really that bothered, to be honest. He was saying he didn't want to spend a lot of time looking at the causes. He just wanted to identify that the equality was there, you know, is there, and he's more concerned about what are we going to do about it. So it's a sort of a difficult approach. Overall, the criticisms can be quite useful, but they don't really detract from the fact that, as Wilkinson said, equality needs to be addressed and changed, you know. He didn't want to spend all his time looking at the causes. So a quick summary to conclude: health inequalities are a pervasive element of modern day health. It doesn't matter where you are in the world or what sort of, when you're in a social hierarchy, there is a relationship to how it affects your health. Lower down the hierarchy are, your worse your health will be. Higher up the hierarchy, the better it will be. Overall, the higher your income, your health will be better. And the richer you are in society, the more unequal other people will be to you. So, quick summary points to think about. They do exist, and it relates to inequalities. The inequalities in health directly relates to inequalities in society. Doesn't just affect those at the bottom of society, but all the way along the grid. In more equal societies, everybody's health is better than those in more unequal society. Even those at the lower part of it, it's generally better than those where there's a big equality gap. Global income inequalities are increasing, so across the world, more and more countries are becoming more and more unequal, and the top 1%, top rich 1% are increasingly leaving the other 90% of the world further and further behind. They're getting richer and richer, so the gap's getting bigger and bigger. Inequality affects health through a variety of mechanisms, and the few examples I've given you is that increase in narcissistic behaviours, disempowerment, and the creation of a toxic and competitive and unforgiving society. So people actually just not caring enough about other people. That's quite an important thing as well. Here's a little references from the book Understand the Sociology of Health. And that's the end of part 3. Okay, we'll be looking at your assignment a bit more in part 4, and I'll go over some of the things you're expected to pick up. Okay, in extra reading, there'll be a couple of case studies just for you to sort of give you something to read, to think a little bit more about what's been said here. Okay, thank you very much and goodbye.